Welcome, everyone. My name is Ashley Scala, and I'm the Education and Information Chair for Miles for Hips. And today we're with Dr. Salil Upasani of Rady Children's Hospital, and he's here to introduce himself. I'll let him introduce himself and what his practice is and his setting. And go ahead, doctor.
All right, great. Thanks. Hi, Ashley, and hi, everyone. My name is Salil Upasani. I'm an associate clinical professor at UCSD, University of California, San Diego, and I work mostly at Rady Children's Hospital in San Diego. I'm the director of the International Center for Pediatric and Adolescent Hip Disorders and the director of our clinical fellowship in pediatric orthopedics and scoliosis in San Diego. We're also working with UCSD to build a unique center to take care of all hip conditions from babies up to arthroplasty as well as revision arthroplasty. So Rady Children's is, a primarily academic practice. We're a level 1 trauma center. We're the biggest pediatric hospital on the West Coast, so very high volume. And my practice primarily focuses on hip and spine pathologies in physiologically young and active patients.
That's fascinating. I can definitely see the correlation between hip and spine issues for sure.
Yeah.
What interventions do you most commonly use in your practice?
Honestly, I think most of my interactions are geared towards patient and family education, right? Like, I think there's not enough information, or at least good information out there about what causes some of the symptoms that our patients feel in and around their hips. So I spend a lot of time talking about the anatomy, the pathology, so what's causing the exact pain that you're feeling. And then educating them about lifestyle modifications, risk factors for progression of the disease, and then obviously going into some of the interventions that we can do to help. So in terms of non-operative interventions, I work with bracing a lot in children, so Pavlik harness treatment as well as hip abduction bracing. We also work really closely with our physical therapists for muscle strengthening, hip range of motion exercises, kind of improving the mechanics of the hip joint. And then obviously my most favorite part is all the surgical interventions that we do for hip preservation to improve the mechanics around the hip joint, as well as treat some of the intra-articular pathology that can occur.
Wow, that is a vast range of interventions for sure.
Mm-hmm.
What led you into orthopedics and hip preservation in particular?
Yeah, I think obviously the patients, all of it has to be number one. So I love the patients that I get to treat with these conditions. I'd say the vast majority are very active. They're motivated to get healthy and back to full function. So that was a big reason why I chose pediatrics instead of adult orthopedics, but I take care of adults up to about age 40 or so. They let me treat at Rady Children's. I also like hip preservation because of the complex anatomy of the hip joint. I love the 3D interactions and kind of the thought that goes into how the femoral head is articulating with the acetabulum, as well as all the soft tissues around the hip joint. I find the surgical procedures exciting, the periacetabular osteotomy, as well as the surgical hip dislocation. So yeah, it's complex pathology that I like to deal with.
Very much so.
Mm-hmm.
Yeah, reading any of your papers and anything is very fascinating, as well as reading anything about hip dysplasia can be very complex to understand for the patients, for sure.
Yeah. So the goal is to boil it down, right? Simplify it so everybody's all on the same page.
And educate. Absolutely.
Yeah.
What is your favorite part of your job?
So favorite part would be to help patients, obviously, to optimize their function, decrease their pain, get them back to doing the things that they love. At Rady Children's, obviously, I love the interactions with parents. I'm a parent myself of three kids that are, now out of the painful years, I'd say. I have a 12-year-old, 10-year-old, 8-year-old. So they're a ton of fun to be with, and they're extremely active. And I can completely relate and connect with families that, want to get their kids back into those types of activities. Yeah, and I think like pretty much daily, I would say that I get really positive, happy feedback from families. So that definitely keeps you going. It's funny, my wife, when I get home, I tell her about, the interactions that I have, and she's at home with the kids, or, the interactions that she has in her daily life aren't necessarily so positive and reinforcing. So it kind of keeps you going. So you work really hard, but you definitely see the impact that you're making in other people's lives. So it's extremely gratifying.
That's awesome. What challenges do you encounter?
Oh, interesting. Yeah, there's definitely challenges throughout the day. I think my main challenge, so I feel I'm inherently optimistic. Once you get to know me, you will see that I'm always, just no matter how complicated the case will be, I always have an optimistic outlook. So I need to do a better job about managing expectations. So especially some of my adult patients, I talk to them before surgery about the expected course, and I see the teenagers and like late adolescents just bounce back from something like a PAO. And I've been told by some of my adult women that I need to be more realistic. That it's going to take more than 6 months to get back to full function, and that you don't bounce back as quickly as you expect. I guess the other challenge, there's always like a never-ending volume of patients, so I need to figure out how to balance the time I spend with each patient, and then balance that with trying to help as many patients as possible. So obviously that's a big challenge. And I guess when it comes to balancing work and life is all of our challenge. So again, with trying to be actively involved in my kids' lives, it's always hard to make it all work, but keep trying to be better.
Absolutely. How does early intervention contribute to improved quality of life?
Yeah, so early intervention, I'm definitely a huge proponent of early intervention, early diagnosis. I think what nature or God, if you believe in that concept, what the human body is capable of going from infancy through childhood to young adulthood. There's basically nothing that we can do that can mirror that. And so I'm a huge proponent of identifying, of diagnosing hip conditions, especially things like hip dysplasia early. And that also gives us a chance to have non-surgical interventions that have proven track records to being extremely helpful. So I think the ultimate goal of all of our hip preservation procedures are to help patients keep their own anatomy, their own bone, their own cartilage. And we haven't yet figured out how to reverse the pathology involved in arthritis. And so the best that we can do to prevent arthritis is kind of what we're capable of achieving. And so the earlier you diagnose something, the better chance you have to impact the natural history of the disease that patients are faced with.
For sure. You spoke earlier about your different interventions you use in the office, including the Pavlik harness. Could you explain a little bit more what the Pavlik harness is?
Sure. Yeah. So the Pavlik harness is a brace. That's kind of the most common brace used to treat infant hip dysplasia around the world. The Pavlik harness was developed by this gentleman named Arnold Pavlik in Czechoslovakia. And it actually happened during World War II. So he was, obviously had a difficult time getting the information out to the West from the other side of the Iron Curtain. But he published a bunch of studies in the 1950s just showing his experience with the harness. And then it spread to the US in the 60s, and obviously came to the East Coast first, where some of the top centers on the East, like Toronto, Sick Kids in Toronto, DuPont in, in Delaware, and Boston Children's and CHOP had some of the early experiences with it. And then since then, it's basically, become the #1 brace used to treat the entire spectrum of hip dysplasia.
Now tell us how you use the padlock harness in your practice.
Okay. Yeah, so it's my first line brace option for the entire spectrum. If you look at kind of the textbooks or published articles, most people say that the padlock harness is most effective under 6 months of age. But we oftentimes use it, up to 12 months, even beyond, to try to treat hip dysplasia. The primary job of the padlock harness is to help hold the hips in the human position, or the M position, which keeps the hips flexed up and abducted. And it's kind of a dynamic brace that uses gravity and hip position to gently relax the tightened muscles around a dislocated hip and allow the hip to find its way back into the acetabulum. So you definitely need a full team of providers there with you to work with the patients. So I have a fantastic nurse, amazing PA, orthotechs. The entire clinic kind of has to be geared towards educating families about how to use the brace appropriately, and how to deal with any hiccups that might come up along the way during the treatment. And I think what makes us unique in San Diego too is that we have very close interactions with our radiology technicians, especially our ultrasonographer. So that's a great way to evaluate and follow how the hip is improving with the Pavlik treatment.
That's fascinating. I can imagine that using ultrasound would be very valuable in treating with the Pavlik.
Yeah, yep. Especially in these young kids, because under 6 months, there's very little bone around the hip joint. So being able to evaluate it, see the cartilage, and see how you're, successfully getting the hip reduced.
How do you anticipate hip dysplasia care changing over the next decade?
Over the next decade. So yeah, I think there's going to be a lot of improvements. I mean, despite the fact that we still use the Pavlik harness and it was developed in the 1950s, so clearly there's room to improve there. So I'd say advances in brace treatment, to see if maybe we could individualize the mechanics of hip reduction for specific patient characteristics. I think there's room to study the benefits of ambulatory bracing for early hip development. So basically what that means is, as the child is first starting to walk, if you're able to hold the hips in an abducted position, slightly open, kind of like a cowboy standing position, there might be improvements to how the head and the acetabulum interact, and that we could see significant improvements in acetabular development. I think we need to do a better job of understanding the three-dimensional interactions between the femoral head and the acetabulum, especially during childhood, because right now, the main technology that we use to evaluate the hip in 3D is a CT scan. And that's kind of been shown to be most effective after age 8, when there's enough bone around the hip. But what we need to start using either ultrasound or MRI to look at the cartilage, look at how the hip is developing, and understand those 3D relationships, to again understand the pathology better and improve our treatments from it. And then the other big thing that we're working at with the International Hip Dysplasia Institute and the registry is to help better diagnose DDH at a younger age. So if you look at when hip dysplasia is typically diagnosed in the US, it's under age 1, closer to 4 to 6 months of age. If you look at that same number in India or China or Africa, that's far beyond after the child has started to walk. So as we talked about earlier, earlier diagnosis, earlier interventions definitely have a much more positive impact on how the hip develops. So improving those diagnostic capabilities around the world is extremely important.
Absolutely. What questions would you recommend your patients or parents of young patients asking prior to surgery?
Yeah, I feel like maybe you're better suited to answer that with all the surgeries that you've had around your hips. I think, so again, what I spend most of my time with is explaining what the problem is, so I'd say parents should ask, or parents or patients should ask, like, what is exactly my hip condition? What is causing my pain? And how does the intervention or the surgery help? So I feel like patients need to wrap their brain around the underlying problem and like how we can make mechanical improvements. As orthopedists, we're very simple minded, actually. It's like mechanics of the human body. So I feel like they need to understand how those interventions can actually help the mechanics of the hip, what alternatives are available to them, what complications should I be prepared for. I think a very important question is to try to connect with patients who have been treated by that provider before, so any provider should be able to get you in touch with pretty much the exact type of patient that you are, your age, your diagnosis, the treatment that they're recommending, and then again, what to expect with their recovery. I think to get a good sense of what you're getting yourself into.
Very good. I like it.
Mhm.
Who have been your biggest influences during your career?
Ooh, my influences. I'd say, so the whole reason I went into hip dysplasia or treating hips have been my mentors along the way, right? So I did my residency in San Diego. So Dennis Wenger and Scott Mubarak are kind of like the hip gurus, very well known around the world. So they were my mentors during residency, and then at Boston Children's during fellowship. Michael Millis, Young Jo Kim were definitely extremely influential on how I thought. I spent some time in Bern, Switzerland after fellowship. So, Professor Gans himself and Professor Siebenrock have been extremely influential. I'd say obviously my patients have been extremely influential. So while you can be comfortable with what the textbooks say and what your mentors tell you is supposed to happen, your patients are the real story, and they tell you day in and day out how the interventions that you're doing actually work. So I continue to learn from them every day. Yeah, and so I'd say that just being honest about your outcomes and closely monitoring how your patients are doing is extremely influential in terms of how you're going to treat in the future. So being at an academic institution really helps to have a team of researchers and students and fellows that are critically evaluating your work and then helping you to kind of objectively analyze your outcomes. So I think that helps a lot.
Definitely see why they would be your biggest influences for sure.
Yes.
I have enjoyed reading a lot of their work, and I've met a couple of them,
Oh,
and they're absolutely amazing individuals
yes,
for sure.
absolutely.
Tell us about your role with the International Hip Dysplasia Institute and why it's important to you.
Yeah, I got involved with the IHDI back in kind of early 2013. I was introduced to it by Dr. Scott Mubarak, again, as my mentor. He took me along with him to one of the meetings. And kind of my initial interactions were primarily research focused. So it was a great resource to, again, enroll our patients, track our outcomes, compare our outcomes to centers around the world. But then since then, it's become like an infrastructure of my closest and most respected colleagues from around the world. So, efforts of Dr. Price, Chad Price, Kishore Multuri, Woody Sankar, Pablo Castaneda, like all of them have been extremely influential in how my practice is developing. We get a chance to share complex cases, teach, patients and surgeons around the world, improve patient care for the entire spectrum of DDH, and hopefully make a lasting impact on improving lives of patients with hip conditions.
That's awesome. We as patients greatly appreciate that for sure.
Yeah, we as surgeons greatly appreciate you patients interacting with us and helping to spread the message and help educate the next generations that need our help. So it's wonderful.
Absolutely. Well, I just wanted to thank you for your time, and on behalf of Miles for Hips, we thank you for your time and thank you for this interview.
Great, no problem. Happy to do it.